Howard?
Sure.
All right, I'll make you the presenter.
Okay, I'll start with this patient. I actually want to put up the scout image. Sometimes I forget to look at the scout topogram. For many reasons, it's good to remember to look at it. This case being one example, but sometimes one sees pathology in the area that is not subsequently imaged on the CT. So it's, for many reasons, a really good idea. So here is a rather dramatic finding on the scout topogram. The clinical context is a patient that had allogeneic stem cell transplantation quite some time ago for, I'm afraid I can't remember what, and I'm not entirely sure why this chest CT was done. So I'll show you first the lungs, which has the dominant finding, which is very typical of constrictive bronchiolitis in that context. Mosaic attenuation is present. There are areas of air trapping. I don't know if I have the expiration series in this exam, but let me bring up some thins and I'll show you that to better advantage. There are a couple lesions like that. I can't remember if I thought that might be a bronch bite from a bronchoscopy rather than a lesion in the apical left lung. There's some intraluminal material in the airways, but the dominant finding, particularly in the lower lung zones, is the bronchiectasis, very substantial, and particularly in the left side, findings very consistent with constrictive bronchiolitis. So I'm not entirely certain whether there's some acute pulmonary parenchymal process that's going on. And then indeed, if one looks into the abdomen, one confirms the presence of extensive pneumatosis intestinalis. There is definitely air in the retroperitoneum about the right kidney. And I'm trying to remember whether I think I did see maybe a little bit of intraperitoneal air as well. That was a surprise. The patient did not have abdominal symptoms at the time. The patient was admitted and was managed conservatively and did okay from the abdomen point of view. So when we look at the list of both benign and life-threatening causes of pneumatosis intestinalis, for sure organ transplantation is one of the things in that list. And this is really a nice example of that in this particular patient. So they recognized that, they knew about it, and again, as I said, just watched her carefully. She didn't develop anything, and she did okay from the abdomen point of view. So rather dramatic, but benign, even with the presence of some air outside of lumen of bowel. She did okay. They did an abdominal CT, I'm trying to remember, but there were no findings there to suggest anything serious. So a nice example of that. I think I've seen that. I see that maybe once every couple of years, perhaps, as an incidental finding. The next one is this one. This one's interesting. I came across this the other day. The patient had surgical management of an acute aortic syndrome previously in this, I think I saw in follow-up. So I'll show you the images from the outside hospital. The patient was sent here with this CT. We do not have a non-contrast series to go along with this, but clearly there are findings consistent with substantial intramural hematoma in the tubular ascending aorta and going into the aortic arch. There's also some blood in the mediastinum, so blood is seeping out a little bit. And let's see if there was any in the pericardium. There's a small amount of pericardial fluid only. But when I looked at this again and again, the only place where I thought I might be able to see the communication or a potential communication between the true lumen and the wall is maybe there. But that is all that I saw. So let me show you the op report and the description of what they found when they took this patient to surgery, which I'll put alongside. You can see they identified the intramural hematoma. They said at the end of the case there was a question of a flap in the descending aorta, but they didn't see that in the open technique. We looked down the distal arch. We did not appreciate any distal tears. Of course, they did fix the ascending aorta, put in a graft there. And what is interesting is the fact that, let's see, I hope I have the timing here right. 417. Okay, let me see if I got mixed up here. No, that's right. So 417 is a little bit after the surgery. Sorry about that. And on the follow-up exam, oh yeah, we have a pretty classical communicating aortic dissection in the distal aortic arch and descending aorta. So it's really interesting how that evolved. Intramural hematoma, ostensibly first, surgery, this is the graft, and then on follow-up imaging, super typical communicating aortic dissection. So one wonders if this was something that then developed to make an acute aortic dissection. But we've all certainly seen that. We've all certainly seen progression of an intramural to this, or combinations of intramural hematoma and communicating aortic dissection in the same patient at the same time, or the evolution of it, like this patient, after a short period of time. Any comments about that, other than being just quite interesting?
What was, I was just going to ask you the time frame between the two studies, but you just showed us. It looked like about 5 weeks or so.
Yeah.
That's strange how it was normal at surgery and then the descending changed.
Yeah, it's interesting how they phrased it. There was a question of a flap in the descending aorta. I wonder if they actually saw something, but weren't quite sure, but whether it was actually real. And then, of course, evolved to this. But the patient is doing okay. So interesting. Is David on? Let's see if I can see.
Yes.
Okay. This is going to be for David a contralateral deja vu. So you showed a case 2 weeks ago exactly. And then as things happen, I came across this the other day. So I get a CT and it says follow-up nodule. And I look at the previous CT, where was the nodule, where was it found? Turns out it was found on a calcium scoring cardiac CT. And the reporter simply said there is this calcified nodule in the basal right hemithorax. Didn't recommend a follow-up, just described it as such. And then I thought, okay, they decided to follow it up. So that's January, and the follow-up is April. So I'll bring up the follow-up alongside it. And let me just go back to unsync those. So what I'm going to do now is say I started looking and I said, oh, where is this thing? Where is this thing? Didn't see it, and then said, oh, there it is, down there. Okay, so let me just go to the bone window. And isn't this, David, exactly like the one you showed like 2-3 weeks ago?
Wow.
A little cortex, a little medullary space or whatever, or at least fat in there maybe, but almost identical to the one that you showed. And I want to show you something really interesting, because when I go here and looking where this was, you see there's still a little dot right there. Isn't that interesting? There's a little dot right there, maybe a little fat. So I wonder if it was like sitting there, or it arose from there and then it fell away and ended up down there. But a super nice thoracolith. And for those who want to read things about this, I found this particular article, which actually is really nice. So it's a whole nice article on thoracolithiasis and the idea that maybe this is fat necrosis and how it gets into the pleural space and so on and so forth. But I'll make this big in case anyone wants to get this article, which is actually a really nice article on this topic. Relatively recent, 2017 seminars, the whole topic of thoracolithiasis. So this is David's case, except it's on the right side. Otherwise, exactly the same size about.
Doesn't it look as if this must be derived from rib? This is a form fruste of a rib. You know, my case wasn't as nice as this one in terms of it also looked like rib, but yours really looks like ribs, the same caliber and everything. You know, could this be could there be some piece of costal cartilage that got into the pleural space and then decided to turn into
I don't know. Because some people believe this derives from fat necrosis in the chest, and that the internal component is in fat. I've heard that theory.
looks like marrow to me.
No, can't tell. It's so interesting. It's almost like little trabeculae or something crossing that.
I still can't figure out how it gets into the pleural space. I can understand the theory of this fat necrosis, it calcifies, but how in the world does it get through the parietal pleura?
Yep.
In a way that it's still mobile, where there's not adhesions and other where the pleura's up.
Yep.
Yeah, it's really peculiar. You get it either.
That's extraordinary, Howard. What a case.
Yeah, look at that there. So curious. 2 in a row within a few weeks, just by chance. Okay, Jake, those are mine for today.
All right. Welcome back, David. Do you have cases or?
I do, but I need a little more time.
All right. Well, I can show a few, and then you can go after me. Let's see. All righty. So this is a nice teaching case and good radiograph. You see my screen?
Yep.
So this is a young man who was in a motor vehicle crash at high speeds. Can't quite figure out. One note said he was restrained. The other one said he was ejected. So I don't know what the story was. But important thing is when we look at these radiographs is they're very low sensitivity unless you're looking for major things. But there's some haze up here. You wonder if there's contusion or something. But more importantly is the mediastinal contours. And you can see this right paratracheal region. There's an outward convexity and it's abnormally dense. So the paraspinal line is displaced. The left paraspinal line is more conspicuous than normal, probably because it's displaced laterally. Usually in a thin young person like this, there's not this much soft tissue along the paraspinal lines because it's just mostly a little bit of fat and bone. And then you also notice up in this area that the spine isn't it's kind of difficult to see the vertebral bodies. It looks like we may be missing a space here, but hard to say much else about that. But abnormal, so you have to worry about a hematoma, mediastinal, paraspinal. Here is the soft tissue, the CT images, and you can see already we've got extensive mediastinal hematoma in the paraspinal region. You'd have to think about aortic injury, but also definitely spine injury, and we can see there's clearly a step-off abnormality of the spine, and I'll show you the sagittal. Load. And we can see here very bad spinal injury. This is a flexion distraction injury. So there's hyperflexion, which results in the compression deformity. There's tearing of the posterior longitudinal ligament, allows this anterior listhesis here. You can see the disrupted cortex, narrowing the canal, but there's also rupture of the facet joint. So that's the hyperflexion injury there. And unfortunately, it's associated with spinal cord injury, which these often are because of the narrow location, the narrow caliber of the canal in the thoracic spine, and also the extensive amount of force. I think he also has a little fracture of his sternum here, very subtle. So, you usually would think of this with, a shoulder belt typically prevents this, or at least minimizes it because it prevents that hyperflexion. But if he wasn't buckled and hit the steering wheel really hard, that could do it. Or if he truly was ejected, you could see that as well. So
yeah, terrible.
But a good interface there. This is a case I'm curious if you have any insight on. This was a PE study, and it goes with your case, Howard, in that it's a nice example of a type A dissection, except this one is a true dissection, and so it was suspected pulmonary embolism. So we do see these every so often, and the real reason I'm showing it is so they followed it up with an abdominal CT just to get the full extent. Is I'm curious what you think about this. So the left renal artery here comes off the true lumen, but you can see it passes through the false lumen. And I'm just trying to figure out how to reconcile that. If this is truly a dissection, unless because the renal artery is not involved as far as I can tell, but you see it extending into the flap extends into the superior mesenteric artery right there, and you can see that, and it gets pretty narrowed. But how does the left renal come off the true lumen and pass through the false lumen without the dissection involving the renal artery itself?
It's the...
So I make a coronal of this. Right, so here you can see the false lumen. And there's the left renal artery just coming right out of there, passing right through that lumen.
It's like the false lumen just went around it,
yeah,
around and about it without taking it out.
Because usually one of the renal arteries comes off the false lumen if it looks like that, if it's on the side like this.
Maybe it's really subadventitial hematoma, and there's not a frank dissection at that level. Maybe.
Yeah, that could explain it. Anyway, it's kind of a curiosity. I don't know how to explain that. But yeah, this one you can see went all the way down and sort of continued into the right common iliac and then sort of fizzled out right down there. All right, well, I don't have a good explanation either, but I was just curious if anybody else did. Okay, this is a nice case. This was a patient who had, let me see if I can find, so here's an old radiograph. So this is a large patient, has a history of some emphysema. This is just to show what the normal configuration of the heart mediastinum, and had some kind of underlying infection, was admitted, was getting ready to go home from the hospital, had been transferred here. So here's an earlier image, and you can see had some atelectasis in the base, maybe some volume loss on that right side. And then I'm going to put up a series of chest radiographs. So move this out of the way. So if we look at the time frame, this is time point 1. This is 2 days later, and this is another 2 days after that. So the first and the last one are about 4 days apart. And the only change is in this superior portion of the aorta here. You can see there's a new interface. This before. So there's the aorta. You can see maybe a little something there if you go back. But compared to the original one from 2016, which I'll put here, you can see normally it was just the aorta. So there's a little bump there. Harder to see on this one. But then on this one, this bump gets a lot bigger. And then there's the calcification along the aorta. So, and you'll notice there's mass effect on the trachea that seems to be increasing too.
That is interesting. Something's going on.
Yeah, so let me show you what's going on. We'll close these and make these go away. We'll bring in the CT here. So I got a CT because my colleague Chris Meyer raised the concern of a aortic problem and hematoma or something. And indeed, there you go. There's your aorta, and then there's blood, and then a little rupture. And it looks like it's right between this plaque. You can see there, and then there's just a little blood, and then you see the arch vessels are preserved, but it definitely gets around the origin of the subclavian artery. But we've got this hematoma all mashed in there. So they ended up treating this with a stent graft. And the question was it a pseudoaneurysm, aneurysm? I don't know the answer to that. I don't think I can tell. I think it's maybe a ruptured atherosclerotic ulcer, given that there's plaque on both sides of this little collar here. And then there's some, you can see a little bit of involvement. There's this thrombus in the subclavian artery there, and another plaque at its origin too. So I suspect this was an atherosclerotic plaque that ruptured. But in somebody with an infection, you always have to think about a mycotic pseudoaneurysm. I think it was starting to move a few days before he was transferred here, but clearly something changed and it ruptured, whether his blood pressure got to normal again, or he was hypertensive, or it just happened when he was still in the hospital. So anyway, they put a stent graft across this, and it looks fine now. It's excluded, and the hematoma is slowly resolving. But I don't know
when you scroll through that proximal left subclavian artery, there's something.
Yeah, there's a filling defect in there, a little thrombus probably, and then there's narrowing of the neck, the origin.
Gosh, that's so interesting.
Yeah.
And the patient wasn't clearly say septic, and maybe
Not
with
at the
bacterial.
time, not really, not that I know of. But you know, in retrospect, after I dug through the chart a little bit, it sounds like he was having some chest pain at this point, and so this was probably starting there. But yeah, it's interesting on a radio. I mean, that was the only change, is that really that this new interface right there, and then you know,
Wow.
massive. Yeah, it was a great call.
It's
Okay.
kind of a versus infection or infection.
Yeah. Now I have two interesting cases from our observer Mohammed, who's been with us, who's from Malaysia. I've shown a couple cases before. So this is a patient with this very interesting CT. Has sort of these ill-defined nodules around the airways and some of the vessels, a couple little cystic spaces in the lungs as well. And there's a larger area, sort of a larger nodule here, and some almost not quite tree and bud, but some branching-looking nodules down in the lower lobes. And this patient carries a diagnosis of Sjogren's syndrome. So anytime I see stuff around airways and stuff like that, one of the things to consider is a lymphoproliferative disorder, like lymphomatoid granulomatosis. I've seen give this kind of irregular nodules, but this patient did get a biopsy, and this is all lymphoid interstitial pneumonia. These are probably lymphoid aggregates, and it has been described to look like this. LIP is not just cysts; it's not just cysts and nodules, but I have cases of consolidation, ground glass and septal lines, and then this one is sort of bronchocentric, well, really, but angiocentric, bronchocentric nodules sort of appearance.
How about follicular bronchiolitis? That's the kind of lymphocyte infiltration.
Right, I agreed, and I think it's sort of a spectrum. To me, that's more localized lymphoid hyperplasia around the small airways, and if it expands into the interstitium of the lung, it's called LIP. But you know, histologically, what I've been told and what I've read is LIP causes quite extensive expansion of the pulmonary interstitium and almost distorts it with so many lymphocytes. So it makes sense you would not just see little nodules and cysts, but you should actually see some denser opacities, whether something like this or more, you know, confluent ground glass.
Mm-hmm.
But I think it's just a pretty example of this. I'll put up a MIP, and I think it's been stable over a few exams. I mean, a coronal image, but it's been stable over a few exams. But it's not always cysts and nodules.
I saw a case like this the other day, which when I get everything together, I'll show, because it's quite similar to this. So I think too, my patient, like this one, has the LIP florid, and then the cystic spaces are the consequence of the deposition of immunoglobulin-associated light chains and the cystic spaces that result from that.
Okay. And then
this one is florid.
Yeah, it's pretty intense. So this is another case. So this is another interesting diffuse lung disease case. So this patient, this was the scan a couple years ago. And if you look, there's some peripheral little cystic spaces, but there's also some subpleural consolidation and ground glass opacity that sort of looks a little organizing pneumonia-like. We see some air bronchograms. Okay, it's giving it, there we go, pinwheel. But you can see this looks a lot like some organizing pneumonia. And then there's these large cystic spaces in the lower lobes. You know, some look like honeycomb cysts, but some of them are quite large. And there is a fine reticular abnormality. So, you know, maybe an acute on chronic fibrotic lung disease with an acute exacerbation, or sort of a mixed NSIP, OP picture. But the reason I'm saying this is, look what's happened now in the course of 18 months to this patient. So now we've had marked progression of these cystic spaces, sort of this macro honeycomb cyst, which, you know, has been described in connective tissue disease. I mean, it's just striking how this lung is just, these large cystic spaces have formed. And, you know, I raised the question of connective tissue disease. I think I just saw this one first without this scan, and was one of my thoughts, and I don't think we have results of that. But as far as anyone knows at this point, there is no connective tissue disease. It may just not have declared itself, but I can't recall UIP progress rather quickly in some patients, and I've seen OP progress onto fibrosis, but I can't recall seeing one that just gave these giant cystic spaces like this. It's actually expanding the lungs as opposed to causing more volume loss.
Right. There's not a lot of scarring, and that's why it's not really honeycombing.
Right.
It's not. There's no matrix of fibrosis that this is occurring in. So
Right.
This
If you
is,
look at the airways, I mean, there is some traction bronchiectasis, but it's not that severe.
and sarcoid's not been in the differential on this person.
I don't think so. It's a kind of a funny distribution for sarcoid. It can occur, but it's so strikingly basal predominant.
Yeah.
Yeah, I've seen big cysts in sarcoid, but it's usually just a lot of them are airways that are more in the upper lobes, or almost cavitary. But and they were present. You can see they were present 18 months earlier, but they've really just taken off. So it was a cool case, but I can't recall seeing something like this before. And it's striking how the lung volumes actually got larger.
So there was a case that had biopsy, and you know, it was called honeycombing, and it had this pattern that Rod Schmidt looked at a few years ago, and he said this is really emphysema. These spaces are emphysematous spaces. So something is digesting the lung here.
Yeah.
I think you know, I think we need to have a category of bubbly lung disease, and then you know, this case and other mysterious cases ought to be written up and published as bubbly lung disease that is, at first blush, you're going to call it honeycombing, but it doesn't have the fibrotic component and what's really going on. So we got to combine cases for this mystery.
Because honeycombing is really what's left when the pulmonary lobule collapses down as there's progressive injury and collapse of the alveoli. And it's really the small bronchiole that's been left behind, and everything collapses around it. And that's why we struggled with, luckily we don't really have to as much anymore, but with traction bronchiolectasis versus honeycombing, it doesn't really matter. But to me, that's what the so-called honeycomb cysts are. We're just stuck with a poor terminology that it's not the same as the pathology. But a bronchiole can't get this big. That's why, yeah, I like maybe it's an emphysematous space that has fibrosis in the walls or something. But you know, you see that in the smokers with IPF that have bad emphysema. They get those really thick cystic spaces, often posteriorly.
Mm-hmm.
That air in the in the pathology, sometimes they refer to as airspace expansion with fibrosis, where you get collagen in the walls of what's left of the alveoli, and then this airspace expansion, which is what we call emphysema. So anyway, these were really two nice cases I wanted to share and see if anybody's seen this with the cyst, and then just that's a less typical LIP manifestation, but it is one that's well described.
And we don't have an exploration series, Jeff, on the last case to look at, just to see to what extent those cystic spaces get smaller on exploration.
No. All right, well, that's what I have for the week. David, you ready?
I'm ready.
All right, here we go.
So can people see a radiograph here of a woman with messed up looking lungs? Looks as if there's scarring and emphysema, particularly up here. So you won't be surprised to see all of these big spaces in the lung here. So bad case of emphysema. I mean, there's a discrete component to this emphysema. There seems to be some pretty well-defined space.
And the vessels are preserved as well, David.
Yeah. So
how about lamb?
You like lamb?
I like lamb or some other, really bad cystic lung disease. I mean, there may be some emphysema admixed in there. I mean, but or LIP plus emphysema. I mean, you can see that cyst right there with the big vessel going around it. But I mean, with emphysema, to me, the vessels sort of go away or get small. And in this case, the intervening lung is normalish.
Yeah, but but we do have some. These cysts are not empty. They seem to have. Maybe we're just seeing cyst walls, but maybe we're seeing some residual arteries and tissue strands and these things that would make me think that this could be emphysema. I thought of Langerhans cell histiocytosis as a cause of cysts that get to be quite large and irregular and look really messy. Lamb tends to stay preserved as discrete cysts, and they don't acquire these big, lobular shapes to them, stuff like that. So I would, if I had to choose one of the cystic lung diseases, I'd probably go for Langerhans cell. I don't know. What do you guys think about that?
I think it's more basal predominant, which would argue against LCH. I mean, it goes all the way down, and I mean that left lower lobe is in bad shape. But if you go up a little bit, there's actually fewer holes in the lung.
Yeah, the distribution. That's a good point.
Sense. I mean,
Yeah.
there are weird Is that there are weird emphysemas, so I guess that could explain some of it. But
sometimes you get discrete emphysema. We've talked about that before.
right. I've seen, looks like cystic lung disease.
This looks paraseptal emphysema here along the mediastinum. Okay, so that's what I thought, that it was something. Now here's an older CT on the same person now. This is from 2011, so this is 8 years ago. And here's what things looked like a while ago. Very discrete.
Those look like cysts.
Yeah, they're cysts. Okay. And this person has Sjogren's syndrome. So, and also has some lupus-like features and has pleural effusion, and at varying times has had his pericardial effusion has had left pleural effusion as well. So I think we're back to the LIP notion here as the cause of cystic lung disease, and dramatic progression in 8 years and really messy looking cysts. LIP cysts tend to be worse in the bases, and hers end up being worse in the bases, unlike, say, Langerhans cell, which spares the bases to some degree. So this is probably all related to her autoimmune disease. Now, it's not a clean diagnosis of Sjogren's. It's some sort of overlap, and I'll ferret out the most sophisticated interpretation of the rheumatologic features on this. But this is cystic lung disease. I wanted to show this case when Howard was here, and it's Jeff. Thanks for showing the LIP variant that you showed earlier, because I think this is another LIP version.
Yes, I agree. And if you go back to the messier scan, there was some of the cysts were perivascular, although to be fair, when they get really big, you can make anything perivascular. Yeah. You can see a lot of vessels running in the walls of some of these. But if you just had this scan, I think it's going to be really hard to reach that diagnosis. But with the
So once again, the time you have the best chance of making a diagnosis is when the findings are early, before they get to be as messy as this. Okay, so here's another case. I've got this 2019 study here to show you of another fellow here who has some discrete cysts in the lungs, and he's got some other stuff going on in his bases. It's hard to, some of this basal stuff has come and gone, so there may be a component of aspiration going on here, but he's got this these cysts in the lungs, and I'm not sure that he has some lung fibrosis. That's iffy because things have come and gone. Here's what his earliest CT scan that we have in our system looked like. This is back in 2012. And I think at this point he didn't have any lesions, or he had just a couple. And this fellow is also thought to have this is another autoimmune disease person that has some features of Sjogren's syndrome here. So I brought up with our rheumatologist, Howard's, pointing out the importance of light chain deposition disease and the formation of cysts in the setting of Sjogren's disease. So he kind of liked that idea. Okay, so Howard, I'm trying to build your fame. Eventually there will be monetary rewards for all of this, not just fame, but bullion too.
Well, stop there. What about immortality? Actually, not immortality. About progression of age and immortality.
There we go. Okay, and then here's a person with a fairly normal chest radiograph. I don't know, maybe a little bit of stuff below the hilum. This is an outside radiograph, so they've reversed the lateral view. And here's what things look like on CT for this person. There's a blob here in this left base. and the blob contains a very large vessel coming off the aorta and heading into the lung alongside the inferior pulmonary vein. So we have this systemic artery going into the medial left lung, and the lung parenchyma around this blob is pretty normal. There's a little bronchial wall thickening down there, but there's no emphysematous component. There's no cystic component. I don't know. Maybe on an activist day, I'd say maybe there's a little emphysematous component back here.
Maybe, yeah. Maybe
yeah. So let's include that. So that goes with this. So this is this lesion was resected, and they're calling it a sequestration. It's got a congenital systemic artery going to it. It's not. This is not acquired neovascularity, a la chronic inflammation. This is clearly a congenitally abnormal artery coming off the aorta. It's very large for the size of the lung that is getting the perfusion. But people were a little confused by this case because there wasn't a big lung lesion. I think this, looking at it again today, I do think that there is an emphysematous component. So this is probably part of our congenital abnormality back here. But there wasn't a big thing, and there wasn't cyst, there weren't fluid levels and things like that. So it was a little hard for people to take this as sequestration, but it fits. We've got a systemic artery, we've got abnormal lung. In this case, it's fairly solid looking. I didn't measure. Let me just see what CT numbers are here to see if you could say that this is mucus. No, it's mean of 34, so it's lowish for soft tissue. It may be inspissated mucus or something, or dry, concentrated mucus giving us CT values along those lines. So, a fairly small sequestration, but a big artery, that's just fine for sequestration. Even though we're not seeing classic big findings, it still fits with sequestration, and this emphysematous component is probably part of it.
Yep, a little bronchiolitis obliterans focally with a little hyperinflation.
So I think that people were pursuing the diagnosis of aortic disease here, so we have these very nice aortic reconstructions here. I think his presentation probably suggests there could be aortic dissection or something. And here's our systemic artery coming off the aorta going into that thing.
Why was it resected, David?
I need to look in the history and find out. Normally if they find sequestration around here, the notion is you should resect a sequestration because you don't want to wait for it to become infected and become a big mess. Once it's infected, it's harder to resect. You can't do it acutely, and then you get adhesions and things like that that make it hard to do after the acute infection has subsided. So the idea is if there's sequestration, to remove it. And I did see one earlier radiograph that suggested he might have had infection in the left lower lobe at one point. There was some consolidation on his outside films that resolved afterwards. So I'll check the history and find out specifically why they did it in this case. But the reflex around here is to resect sequestrations before they become infected problems.
We tend to leave ours alone because usually we pick them up middle age or older, and at that point, if you made it that far, it's probably unlikely to cause any problem.
Good point.
But okay.
If you bring it up again one more time, David. I wanted to see if I could see any mural calcifications at the origin of that vessel, close to where it originates from the aorta. Is there any mural calcification in it anywhere? I think you had a non-contrast or.
Yeah, there was a little dot of calcium at the origin right here. Just a tiny little dot. But what we observed way back in the 80s when we first saw sequestrations on CT was that it's not unusual to have premature calcification of the systemic artery that's going lung lesion.
About that when you showed that, I thought, cool.
That could be
hard to say. It's so small.
Okay, those are my cases.
All righty. Well, thank you guys.
Yep.
Glad our technology issue is fixed, and so we're all good to go.
Excellent. We'll have
Travis is back
more.
next week. I'm here next week. So
what is the meeting this week? Is it AUR or ACR or something like that?
AUR.
AUR. Okay.
Yeah. All right, guys. Talk to you later.